Hello, I'm Dr. Aizaz from MedicoVisual.com, and in today's visual lecture we will discuss mainly about role of respiratory system in pH balance, but along with that we will also discuss briefly about the hemoglobin buffer system. I have discussed about the hemoglobin buffer system in another video as well, but today we will dig a bit deeper into it. And along with that, a very important concept that must be discussed today is the concept of Bohr's effect. Bohr's effect, and there is something related with it, that is Haldane effect, and yet another thing which is related with it, and that is called the chloride shift. Now all these things are very related to each other, but they are not same. Many people get confused, they mix up these things, but today in today's visual lecture we will understand it conceptually and thoroughly, and we will learn it once for all, so the students, you do not get confused between these three things. So in the previous lecture we had discussed about the bicarbonate buffer system, and I've told you that bicarbonate buffer system, or rather any buffer system, it consists of two parts: the conjugate base, which is the acid fighting part or acid fighting soldier as I said it, and that is, in case of bicarbonate buffer system, it is bicarbonate ion, which is the conjugate base, and it has the base fighting part, which is the acid part, which is H2CO3, or we can replace H2CO3 with the CO2 because these are directly corroborated, they are in sync with each other, right? So now what happens that if there is too much base coming, that any base is coming, so what will happen, that this acid H2CO3 or CO2, it will fight with the base. This is the base fighting soldier, it will fight with the base and it will begin to decrease. It will begin to decrease and it will begin to convert itself into HCO3 negative. So the conjugate base alkali will increase. Similarly, if acid is coming, too much acid is coming, so what will happen, that the this base, the conjugate base, which is the acid fighting soldier, it will decrease. This will decrease and the H2CO3 or CO2 will increase. Now, of course, this cannot go on and on forever. There is a limit. So these components must be replenished. These components of buffers, any buffer, and mainly the HCO3 and H2CO3, the bicarbonate buffer, it is the major buffer of our blood. So its components must be replenished. And what thing will replenish these components? The CO2 part. Of course, we all the time we exhale out CO2. So this part, it is directly related with our respiratory system. So what our respiratory system can do, if CO2 level is becoming low, let's say in a normal person, I'm talking about, that if CO2 level is becoming low because it fought with the base, let's say, then what will happen, that our body, our respiratory system will try to retain the CO2. So rate of respiration will become low. We will hypoventilate. Similarly, not similarly, in the opposite side, on the flip side, if the CO2 is very high, like in this case, it was fighting with an acid, CO2 is very high, then the person whose CO2 is high, he or she will hyperventilate, rate of respiration will increase, right? And there will be deep breaths, deep and rapid breaths. So hyperventilation will be there. Now this is, I'm talking about the person whose respiratory system is normal, right? But what if respiratory system itself is abnormal, and due to that pH disturbance is there? We will discuss this in later lectures when we will discuss the pH disturbances. But here let me give you a sneak peek that this I was talking about the role of respiratory system in normal person. I mean the person whose respiratory system is normal. But if okay, let's suppose there is severe asthma or anything related with respiratory system such that the CO₂ is being retained. CO₂ is being retained. It means CO₂ level will be high due to the respiratory system itself. So if CO₂ level is high, it means that pH will decrease and there will be acidosis, and this acidosis is due to respiratory system. So this is respiratory acidosis. Now if there is respiratory acidosis, then this compensation won't be through the respiratory system. The cause itself cannot compensate. So in that case the compensation will be through this. What I mean by this, if CO₂ is high, so body will, our renal system, what it will do is that it will do something with HCO3 so as to somehow, even slightly if possible at all, it tries its best to somehow bring the pH to normal as much as possible, as much normal as it possibly can. I hope you got the concept. So if CO₂ is high, then HCO3 would be retained. The kidneys will retain bicarbonate ion, this alkali reserve. So if conjugate base also become high, there is at least somewhat compensation. There might be full compensation as well, but that is a separate topic. But anyhow, the point is that kidneys would compensate. But in a normal person, normally all the time, what is happening actually is that through our normal respiration, all the time CO₂ is exhaled out because lots of acid is being produced, lot of CO₂ is produced in our body anyways. The oxidation of food, be it carbohydrate, be it lipids, or the what is the third thing, proteins, so it will always produce CO₂, and CO₂ is regularly exhaled out. We do not need to hyperventilate. Normally we exhale out, it's not a big deal. So it is going on all the time. But what if the problem is due to the kidney? Maybe there is something related with the kidney, or it may not be due to kidney. We will discuss in the lectures of metabolic acidosis that what is going on. There may be ingestion of the some drug, so ingestion of any external acid, or due to any reason. Let's say if HCO3 is high, alkalosis type situation, pH will be high, then our respiratory system would compensate. Okay, let me explain this thing. So if HCO3 negative, which is alkaline conjugate base, if it let's say increases, then what will happen? What will happen to pH? PH will increase or decrease? PH will become alkaline. It will increase because this is alkali reserve. So to compensate this, the CO₂ levels should not remain normal. Normally it is about 40 mmHg, somewhat about 40 mmHg. So it should not remain normal. What should be happening with CO₂ level? Should it increase or should it decrease? pH is being high, so it should increase actually. There is risk of alkalosis, or there might actually be alkalosis. So if there is alkalosis, body should retain CO₂ to produce acidosis not actually produce acidosis. I mean to compensate so as to take the body towards the acidosis side so that it compensates. Okay, let's draw something else. If we draw a seesaw, so if let's say HCO3 is trying to take the body toward, it is increasing, right? It is trying to take the body towards alkalosis, so CO2 would increase as well. So if it is taking the seesaw like this, then CO2 will increase. CO2 will increase. So pH might become normal or at least near normal. And how will body do it? It is simple as that. There will be hyperventilation or hypoventilation. Obviously hypoventilation. We will exhale out CO2 less. There will be decreased exhalation of CO2. CO2 has to be retained in our body. Opposite to that, if HCO3 negative is low, if HCO3 negative is low, then pH would become low as well. So CO2 must be quickly exhaled out. So acidotic condition would be there. So CO2 must be exhaled out quickly to compensate for this. This is the concept of respiratory compensation. So two things that you should not mix up. Please understand this thing. One is the role of respiratory system in pH balance. One is the normal role that respiratory system is there normally in everyone. It is doing its job. It is exhaling out CO2. Why it is not normally retaining CO2? Because we produce acid, we produce CO2 all the time, so it must be exhaled out. So that is why you are all the time breathing. That is one reason. Of course, you also need oxygen. The other reason is oxygen. All the time you need oxygen in, you need CO2 out. So that is why all the time you are breathing normally. You cannot survive long without breathing, of course. That's very logical. Okay, so let's move forward and yeah, now we have CO2. Okay, let's suppose CO2 is produced, let's say, due to oxidation of carbohydrates or whatever, or maybe due to, or any acid that has raised CO2, right? So this CO2 must be exhaled out. Now, suppose you have a muscle and CO2 is produced in this muscle, let's suppose. So CO2 is produced in this muscle. Now this CO2 must be exhaled out. So this muscle produces CO2. Now this CO2 has to be exhaled out through your lungs, right? So how it will reach the lungs? Now you would say, of course, through our blood. But how through our blood? Actually, the CO2 can be directly dissolved in our blood. The CO2 can be actually dissolved in our blood, but not so much. Only 2% of CO2 is dissolved in our blood. The other 98% is not dissolved in our blood. It is attached to something which is very well known by everyone as oxygen carrying protein, and that is hemoglobin and red blood cell, basically hemoglobin inside red blood cell, right? So if I draw the red blood cell, we all know very well that the red blood cells have hemoglobin, and hemoglobin is involved in the transport of oxygen. But I know very few people, they know that hemoglobin is also involved in transport of carbon dioxide. Now the place where the carbon dioxide attaches, it is different from the place where the oxygen attaches. The CO2 can directly attach with amino group, the amino terminal. It can directly attach with amino terminal of the peptide chain of of the hemoglobin, and of course we have 4 subunits, so 4 CO2 molecules can attach with the hemoglobin, right? And the CO2 can directly attach with it, and this is called carbaminoglobin. So CO2 can be directly attached with carbaminoglobin. I think it's about 20% the CO2 that is transported through this mechanism. The third most important mechanism is that it is transported by being converted into another substance, and that substance is H positive, the proton. So it can be converted into proton, and that proton is actually attached with imidazole ring of the hemoglobin. So how it happens? So let's suppose here we have CO2. Now CO2 is relatively a small gas, and it can directly cross the cell membrane and enter inside the red blood cell. Now 20% of CO2 directly gets attached with the hemoglobin as carbaminohemoglobin, but rest of the CO2, it is not directly attached with hemoglobin, it is converted into something. Let me explain this. So we have water everywhere in our body, and of course red blood cells are no exceptions. So H2O and CO2, they combine in our red blood cell with the help of enzyme called carbonic anhydrase, and these are converted into H2CO3. Now this H2CO3, it will of course release H positive, and it will also release HCO3 negative. Now, if this HCO3 negative, it continues to accumulate and accumulate, and this H positive, it also continues to accumulate, this reaction will stop. So this H positive, it is quickly picked up by imidazole ring of the of the hemoglobin. It will bind with imidazole ring, and this will become HHB. Right? And this HCO3, this will go out of the cell. This will go out of the cell through a special transporter, and this transporter, I forgot the name of this transporter. Yeah, I think it's called AT1, anion transporter 1, if I'm not wrong. You can check this up. So AT1 is there, but as the bicarbonate is funneled out of the cell to maintain the electrical neutrality, the chloride must come in, right? So this is called chloride shift. It's very easy to understand, chloride shift, and it is also called the Hamburger effect. Of course, it has nothing to do with our beloved hamburger that we love to eat. It is under the name of a scientist whose last name was Hamburger, and he first described it. I think he was a Dutch scientist, if I'm not wrong. But anyhow, that is beyond discussion. So the HHB, it has bound with hemoglobin. The proton, it has bound with hemoglobin. Now what will happen that this red blood cell, from the, let's suppose this process happened in your arm, in the muscle of your arm. So from here, from the capillaries and veins of your muscle, ultimately it will reach to, through the circulatory system, of course, it will reach to your lungs. So let's draw a very big lung, and of course inside the lung here again our red blood cell, a huge one, is there. I'm just drawing a part of it, but anyhow, so here it is, here you see we have hemoglobin. Of course it is attached with not one but actually many many protons. So here the protons will be released, right? And then what will happen that there again we will have this AT1 So through these channels, the chloride will come out, and HCO3 will come in, the bicarbonate will come in, and both of these will combine to form what? To form H2CO3. And this H2CO3, again the carbonic anhydrase will do its task, and it will be converted to CO2 as well as water. Now this is exact opposite of this, whatever happened here. Here exact opposite is happening. So this CO2, it will be then exhaled out through your lungs. Simple as that. Now here few things that I would like to discuss. So let's start from here. Now the thing is that whenever CO2 or H positive protons, whenever they bind with the hemoglobin, they form carbaminohemoglobin or HHP. In any case, or in both of the case rather I should say, what will happen that the affinity of hemoglobin for oxygen decreases. What I mean by this, that if hemoglobin, it binds with CO2 or proton, it loves to release oxygen. Oxygen will be released. Its affinity for oxygen will decrease. And in textbooks, they write a very confusing sentence that the oxygen dissociation curve shifts towards right. What do you mean by this? Well, uh, I will not go into the oxygen dissociation curve, hemoglobin oxygen dissociation curve. That's a different topic. But what actually is happening, that if we draw a graph between PO2, partial pressure of oxygen, and percentage saturation of hemoglobin, a graph something like this, sigmoidal graph will be formed, something like this. Yeah. So what if I draw another graph? This graph is a bit right towards this, like this. Now if you focus that here, let's suppose somewhat here at this point, at this PO2, partial pressure of O2, of course it is going higher towards this side and saturation is going higher towards this side. And at the same PO2 level, if we draw like this, you can see that here the saturation is much higher, but here the saturation is much lower. So if graph is shifted, if the curve is shifted towards right, it means that for the same partial pressure of oxygen, for the same oxygen supplied, for the same oxygen available, there will be decreased saturation. If the curve is shift towards right, there will be decreased oxygen saturation, percent saturation for the same PO2. So what does that mean? It means that oxygen will be unloaded. It is very simple that if CO2 is loaded, CO2 loaded, in simple terms, CO2 loaded, oxygen unloaded. Oxygen unloaded. So what is the implication of this? The implication is that in the peripheral tissues, we need to get rid of CO2. So CO2 will bind. CO2 will bind with hemoglobin, and as CO2 binds with hemoglobin, oxygen will be released because we need to supply oxygen to the tissues. Let's suppose it's a muscle, it is working hard. So muscles are contracting and relaxing, it is working hard, it actively needs oxygen. So, and it needs to get rid of CO2. So when CO2 binds with hemoglobin and in the form of carbaminohemoglobin or HHB, the protonated form of hemoglobin, So oxygen will jump out of hemoglobin. It will become easier to get rid of oxygen from the, it will become easier to unload oxygen from the hemoglobin. And this effect is called, this is called Bohr's effect. This is called Bohr's effect. Now, if you talk about here, now here the something opposite will actually happen here. Here what will happen that the CO2 will be released. So CO2 will be released from, or proton will be released from the hemoglobin. So this will cause the loading of oxygen. So here we need the hemoglobin to be loaded with oxygen, right? Here in the lungs we need to load the oxygen on hemoglobin. So it's very natural that as the CO2 jumps out, CO2 unloads, CO2 jumps out, then O2 comes in, O2 comes in, O2 is loaded. I can write it like this. So what is this effect? Is it Haldane effect? Okay, it is not Haldane effect, remember. It is still Bohr effect. It is not Haldane effect. Please remember, it is still Bohr effect. So then what is Haldane effect? This is very important. This is the point that trips many medical students, and I want to clear it here once for all so that you never get confused. So what is then Haldane effect? Haldane effect is the opposite phenomena to this. So we can say this in another way, that actually here there will be very high oxygen available, right? So here from the lungs, from the alveoli, we will have very high oxygen. So this high oxygen actually can cause the unloading of CO2. It's just the other way of saying things. So we can say O2 jumps in, O2 jumps in, CO2 jumps out, or CO2 is unloaded. So this is actually Haldane effect, and both are going on side by side. It is just that one was discovered by Mr. Haldane and other was discovered by Mr. Bohr. It's the name of those scientists who discovered it. So here what is going on? Here I have told you that CO2 is loaded and O2 is unloaded. At the same time here, another thing is actually happening, that O2 is unloaded, or O2 jumps out, O2 is unloaded, so CO2 loads. And this is Haldane effect. Haldane effect, right? So now I think you should not get confused, and to even make it easier for you, let me explain it in a different way. Now please understand that Bohr's effect is all about CO2 and what CO2 does. Haldane effect is all about O2 and what O2 does. So this is Bohr effect, CO2 loaded. It is Haldane effect, O2 loaded or unloaded. Right? I hope you get the concept. So it's all about the cause, not the effect. We are not going to classify it into Bohr or Haldane effect on the basis of whether the O2 loads or whether the CO2 loads, but we are labeling it, we are classifying it on the basis of cause. If O2 is causing it, it is Haldane effect. If CO2 is causing it, it is Bohr's effect. How can you remember this? First, I have told you it is all about the effect. Second, how can you remember? How can you link the O2 with Haldane effect and CO2 with the Bohr effect? Well, it's my mnemonic. You can come up with your own, but we know that after the letter B, we have the letter C. So Bohr, with Bohr, we have C, CO2, right? Then Haldane, So you know Haldane, or you can also write with H, you can write H2O. So H2O you can somehow link with HO with oxygen. I hope you are clear about this. Another thing, you know, when you talk about healthy thing, the fresh air, healthy and fresh, it is all the time, you know, related with oxygen, healthy oxygen. So you can somehow relate H with O, and you can somehow, you have to relate B with C. So Bohr is related with CO2, right? So if CO2 is causing something with hemoglobin, what it is doing, if CO2 is more, oxygen will release. If CO2 is less, oxygen will be loaded. Similarly, if oxygen is low, CO2 will be loaded. If oxygen is high, then I think I messed it up. So if oxygen is high, oxygen will be loaded and CO2 will be unloaded, and vice versa. I hope you get the concept by now. Well, I can simplify it even more for you. Okay, let's suppose this is a guy, and this guy is this is hemoglobin. Now hemoglobin is sort of a playboy, right? It has two girlfriends. One girlfriend is O2 and the other girlfriend is CO2. Now if it is hanging out too much with O2, then CO2 will not like it and CO2 will jump out. This is Haldane effect. If hemoglobin is hanging out too much with oxygen, I mean, if there is oxyhemoglobin, then its affinity for CO2 will decrease. So in other words, in a technical way, if I put this, that for the oxyhemoglobin, it has less affinity for CO2, or we can also write H positive, don't forget that. Similarly, if this guy, this playboy, hangs out too much with CO2 or H positive, the other girlfriend, then this O2 will not like. So if hemoglobin binds too much with CO2, its affinity for oxygen will decrease, and reverse is true as well. Reverse is true as well, and that still remains Bohr's effect. So Bohr's effect, and Haldane's effect. So I hope after this you will not get confused. Chloride shift I have already taught you, but there is something more to it. Let me briefly discuss that as well. Let's suppose we have arteries. Then arteries will break up into capillaries, right? And then capillaries will ultimately form the veins. Now, what actually they noticed, the scientist Mr. Hamburger, perhaps he noticed it, that the red blood cell in the vein, it has slightly more volume, it is slightly bigger than the red blood cell in the arterial side. Why it is so? So this one is slightly shrinked, this one is slightly inflated. The reason was, and he discovered the reason was that it has more chloride, and this led to the studying and the discovery of chloride shift. Why it has too much chloride? The reason we have already discussed, that here at the venous side the red blood cell has to bind more CO2, and if it has to bind more CO2, we have discussed here that this HCO3 will come out of the cell and chloride ion will come in, and as the chloride ion comes in, the volume increases slightly because water jumps in with chloride ion, right? But so on the venous side there will be high chloride, bit of high chloride on the in the red blood cell, but ultimately this blood through circulatory system, these veins will reach to the your lungs, and here they will be oxygenated, right? And ultimately now on the arterial side in the lungs, as I've told you, something opposite happens, opposite of chloride shift. I think that is also called chloride shift, but in the opposite direction. So here the chloride shift is in the opposite direction, that chloride moves out. So now here this RBC that came from the respiratory system, from the respiratory side it came into the arterial side, it will be having low chloride, it will be having low chloride. So venous blood, RBC in the venous blood is high on chloride, and RBC on the arterial side is low on chloride, and the reason is this chloride shift that I have already told you. Now there is another interesting thing, that as the oxyhemoglobin forms, the oxygen, too much oxygen attaches with the hemoglobin. As I've told you, its affinity for CO₂ decreases. It means that it can bind less CO₂, as well as it can bind less proton. But if it becomes deoxygenated in the peripheral tissues, if it becomes deoxygenated, its oxygen level is low, it is deoxygenated or less oxygenated, Hb is there, it can bind more CO₂, it can bind more proton, it can bind more proton. It means that its pKa changes. PKa or Ka defines the acidity or basicity of a substance. Actually, the hemoglobin, by accepting or donating the proton, it is actually acting as a conjugate acid and base pair. So I can write it in the form of the Henderson-Hazel bulk equation, that we have this the base form, we have this base form Hb, and we have this acid form HHb. Now the pKa changes depending upon whether the hemoglobin is oxygenated or deoxygenated. Let me tell you the implication of this. So for the deoxygenated or deoxyhemoglobin, which is of course in the peripheral tissue, the pKa is equal to 7.9, and for the oxyhemoglobin, the pKa is about 6.7. Now we can write the Henderson-Hazel bulk equation, that pH is equal to pKa plus log base over acid, and base here is Hb and acid is HHb. Okay, now what I actually want to show is this ratio, and to get this ratio I can rearrange this equation. I can write pH minus pKa, right, is equal to log Hb over HHb. Now we can take anti-log on both sides, and anti-log is 10 raised to power something, right? 10 raised to power pH minus pKa is equal to, if I write 10 raised to power log and all this, actually we can cut this out, and log can be cancelled out with anti-log, and it will simply become Hb over HHb. We can get the ratio using this, right? So we can calculate this for both of the above. If we calculate for the deoxyhemoglobin, for the average pH of 7.4, we can take the difference of 7.9, and then we can use the calculator to get the value. So let me open the calculator. So 7.4 minus, what is this, 7.9. So 0.5, 10 raised to power minus 0.5, and where is this? Yeah, so 0.316. I'm gonna round this off and I will just write 0.32. So actually the ratio is 0.32 divided by 1. We can write it, of course, if there is nothing below it in the denominator, it is understood that it is 1. And for this we can again calculate 10 raised to power 7.4 minus 6.7, and we will get what value? Let's check. 7.4 minus 6.7, 0.7, and if we take 10 raised to power 0.7, it is about 5, so the ratio is 5/1. Now I can multiply this numerator with 31 and this with 31 as well. So our answer will be about 10 here, over 10 divided by 31. Don't ask me where I get this value. It is just for your understanding. There is some complex algebra involved here that I will not go into, and here I can multiply the numerator, this one with 2 and this one again with 2, and I will get 10 by 2 here, and I've got 10 by 31 here. Now what I mean by this, that for 10 molecules of non-protonated or deprotonated hemoglobin, we will have 31 molecules of protonated HHB. But here we will have 10 molecules of HB, the deprotonated form, and only 2 molecules of HHB. So what I mean by this, if you look carefully, if I ask you a question, which of these is carrying more HHB, which of these is carrying more proton, this one or this one? Of course, if you look at this, you will understand that the deprotonated is same. That's why I did this multiplication, to show you this concept, that HB is same 10 10. But here we have 31 molecules of protonated HB, and here we only have 2 molecules of the protonated HB. So it means that it can carry more proton as compared to this. So this is the deoxyhemoglobin. So deoxyhemoglobin becomes a better buffer, well suited buffer for this task. And oxyhemoglobin, by changing its pKa value, it becomes well suited actually for its task, that it has to release HHB. What it will do, that when it reaches the peripheral tissues, it can pick up lot of proton. When it reaches the lungs, it can release lot of proton to form CO₂. So it can pick up the CO₂ in the form of protons in the peripheral tissue, and it can release CO₂ in the form of proton in the lungs. So this is well suited for this job. The pKa changes. This is the beauty of hemoglobin buffer system. This is the only buffer system that I know in our body that changes the pKa value depending upon where it is, and it changes because of which effect. Now this is your quiz. I think before I answer this question, please write down in the comment section that is it due to Bohr effect or is it due to Haldane effect? This is the very important question. Don't Google, don't ask AI. Please write the answer in the comment section, and of course I will tell you the answer. It's very logical that it is deoxy or oxyhemoglobin. So it means it is all related with oxygen. So anything which is related with oxygen, depending upon the oxygen, basically it is loading or unloading the proton or CO₂. It is loading or unloading the CO₂ depending upon its oxygenation status, depending upon the oxygenation status of the hemoglobin. So if it is related with oxygen, I told you here, H for oxygen, H for healthy, H for H2O2. H2O2, yeah, H2O2, but H2O. So H is related with oxygen. So it is which effect? It is not Bohr's effect, it is Haldane effect. So I think you must be clear by now, and that was all for today's lecture. I hope you learned something today, and I hope I haven't missed anything important. If I did, no worries, I will teach you in the next part. So that was all for today. Thank you so much for watching this video. Have a great day. Goodbye.